Had a really challenging consultation today. They were in their 70s, didn't really have any other medical problems, but had really bad hip pain. And I diagnosed him with osteoarthritis of the hip. And the treatment for that is usually physiotherapy as the first line treatment, doing exercises, strengthening exercises of the muscles around the joint. And I usually prescribe some sort of pain relief or anti-inflammatory to try and get them out of that initial stage of pain so that it can facilitate them doing the exercises, and the exercise is the treatment because it helps with the bone remodeling, helps with the strengthening of the joint. But when I prescribe anti-inflammatories, I like to prescribe something called Omeprazole with it. This helps to prevent the anti-inflammatories from causing a stomach ulcer and helps to reduce the risk of someone having an internal gastrointestinal bleed, which could eventually possibly lead to death. And that's why I wanted to prescribe the omeprazole, but the patient was having absolutely none of it because they had read that omeprazole can cause osteoporosis. And I was just like, you're not necessarily in the highest risk group for osteoporosis, being a man in your 70s. You've never been on any long-term steroids. You've not been on any other medication that would cause osteoporosis. And you would need to have been on omeprazole for over a year. And even then, only a small minority of patients will develop osteoporosis off the back of it. But he was having none of it. And it made it really difficult because because it was a medication that I wanted to prescribe, I think he then lost faith in me and then didn't even want to really pay attention to the alternatives that I was trying to prescribe, even though I was just trying to act in his best interests, because the theoretical risk of osteoporosis is minimal compared to the very real active risk of causing a GI bleed in someone in their 70s by giving them anti-inflammatories.